Welcome to Care Chats. Join palliative care experts sharing stories, information, and strategies. We're passionate. Join us, and let's get comfortable with palliative care.
Welcome to Care Chats. We are a group of palliative care nurses who are very passionate about providing palliative care and educating healthcare providers on how to provide palliative care. So that is the purpose of our podcast, is to provide information on how to improve the practice of all healthcare practitioners when it comes to palliative care. We'll talk about the topic of our episode, which is just an introduction to palliative care. We're going to talk about the meaning of palliative care, the palliative approach, how to provide palliative care if you aren't a specialist. We're going to talk a little bit more about how to discuss palliative care with patients and families. And then we'll also go through some myths. That'll be probably, in my opinion, the most interesting and fun part of this episode. But let's start with some introductions. I'm Jennifer Lamb. I'm one of the palliative consult nurses here at the U of A Hospital in Edmonton. I've been working in palliative care for 17 years, and I was trained on the tertiary palliative care unit for most of my career at the Grey Nuns Hospital. We are also joined today by Danica Hans, who is the education lead at the Palliative Institute with Covenant Health. She's been working in palliative care for 12 years. She also did the bulk of her training at the tertiary palliative care unit at the Grey Nuns Hospital. And then we also have Brooklyn, who's been working in palliative care for only 9 years. And she's the nurse educator at the Grey Nuns Hospital. She also did most of her training at the tertiary palliative care unit at the Grey Nuns. We are all also coming from the same background. So please keep in mind as you're listening to this that we all have had very similar training and very similar opinions in terms of approaching palliative care and our practice. We'll just maybe add a comment that we do have references for everything we're talking about in our podcast episodes, including today, and everything we've taken from our references is publicly available, so we will provide those links in the video description below. But Danica, did you want to start us off with the meaning of palliative care? What does palliative care mean?
Sure. Thanks, Jen, for the introduction. I'm super excited to be here and to start this series of care chats. So, to get us started and talking about palliative care, I want to stress that palliative care really is a type of healthcare that aims to address symptoms for anyone living with a life-limiting illness. So, the aim is really to increase quality of life through symptom management. That's achieved by looking at the person as a whole person and offering interventions that address not only physical symptoms, which we often think about, but also psychological symptoms, social, spiritual symptoms, as well as suffering, whatever that form that might take. Ideally, palliative care is offered by an interdisciplinary team that works together to offer a variety of interventions and hopefully as early on as possible in the illness trajectory, alongside whatever curative or medical care makes sense to that person and is available to them. People are often actually really surprised to hear that.
That is definitely a myth, and we will be talking about that later on.
You're right, Brooklyn. People often think that it's only for end of life, but we hopefully will convince you that it's not.
Lesson number 1. Danica, do you want to talk more about what the palliative approach entails?
Sure. So, palliative approach is care that's bigger than only providing physical and psychological symptom management. So, it also includes aspects of care that are bigger than the immediate needs of that person. A palliative approach to care can be implemented by any healthcare provider, regardless of their discipline, regardless of their specialty, and really at any point in the illness trajectory. So, a palliative approach to care means talking about a person's goals and wishes related to their serious illness diagnosis, being aware of what's actually important to them.
I'll actually add that we'll probably talk a little bit more in a different episode about specifically advanced care planning and having these hard conversations. But one thing to note, especially with what you just said, Danica, about talking about the patient's goals and wishes with regards to their illness and what's important to them, is making sure that when this patient is being represented by their agent, so in Alberta, it would be the agent on their personal directive, to make sure that the agent is acting on behalf of what the patient wishes, not what the agent wishes. And that I've been told has been referred to as the platinum rule, but I don't know, Brooklyn, if you want to maybe educate us a little bit more on what the platinum rule is.
For sure. So often we hear about the golden rule. So that's do unto others as you would have them do unto you.
The platinum rule is actually do unto others as they would want done to themselves.
Yes.
Thank you both. What else did the palliative care approach involve?
So, other than knowing what is important to that person, you also want to share information and education about disease management and goals of care options. So, make it personal for that person and figure out what their expected illness trajectory is, and talking about that with them so that they can have a little bit of an understanding of what they can expect. It also means including the patient and whoever is important to them in their care planning. And it means adapting your symptom management as the disease progresses and the priorities or the goals evolve and change. The idea is really to support the person's well-being while they live with a serious or life-threatening illness in whatever time frame they might have. And it includes end-of-life care, obviously, as well as grief and bereavement. So if someone isn't a palliative care specialist, but this sort of sounds interesting to them and they'd like to implement some of these principles in their practice, how could they do that, Jen?
Well, I would use the Alberta Nurses Palliative Care Competency Framework, which is an excellent resource for identifying the specific competencies that a healthcare provider can embody in order to provide good palliative care. So, in the framework, they describe three levels of healthcare providers in terms of competencies. Um, the first category is all healthcare providers. So, regardless of your designation, regardless of your experience, everybody should be able to provide this level of palliative care. And then the next level is some healthcare providers, so usually a little bit more specialized, a little bit more knowledge and experience. And then few healthcare providers, which is usually our palliative care specialists. In the all category, we'll go through the 8 domains of clinical competency that this framework describes. So the first one is principles of palliative care, really just understanding the palliative approach and working with other disciplines to provide that holistic patient-centered care. Communication, that includes nurturing realistic hope in the context of illness and goals of care. So like Danica was just talking about the patient's illness and their understanding their wishes, care planning, and collaborative practice. So, again, assessing their needs, their strengths, their wishes, and working with the team to develop a care plan, perhaps. Optimizing comfort and quality of life, knowing how to assess for common symptoms, pain, nausea, anxiety, things like that, and using non pharmacological interventions to help. Something that I can think of, if the patient's really short of breath, maybe turning a fan on, opening a window if they're at home, perhaps checking their O2 sats, or even knowing who to call for help if you need to intervene. The few category would involve knowing how to manage the symptoms of medications and maybe even adjusting the medications. But I would hope that people with a little bit more experience would also know what medications to provide. Dealing with loss, grief, and bereavement is really just everybody should know how to recognize the signs of grief and knowing that everybody's different with regards to their grief experience and maybe even referring to resources. So it's within everybody's scope to provide a bereavement package, for example, or it's within everybody's scope to be able to refer to spiritual care, page spiritual care in facility. Professional and ethical practice and self-care, I'm kind of grouped together in terms of those 2 domains, but it's really just recognizing your own beliefs, how it impacts your own abilities, recognizing your own attitudes with regards with death and palliative care. So basically, you know, knowing your role, knowing your baggage, and being able to set that aside to provide support for the patient and what their wishes are. An example that I can think of, a really great example actually that I can think of recently, is I was approached by an HCA who was telling me about how conflicted she was that a patient she was caring for was receiving MAID that day, because she didn't really understand why, and she didn't really know the whole story of what led up to that point. But she was able to set aside her own uh, beliefs and her own feeling of conflict. So it was able to support the patient that day in the patient's own context with whatever they needed. So really listening to what the patient wanted and being able to support them that way. The last domain's cultural safety, so really just addressing any of the patient's needs that are impacted by their own social, spiritual, cultural experience and values. And then also education, research, evaluation, furthering your own knowledge about palliative care. Everybody should be able to do this. And hopefully this podcast would be able to help you do that. So how do we talk more about palliative care with patients and families? Brooklyn?
Yes. So, as healthcare providers, we may be hesitant to bring up palliative care with our patients because we maybe think that we are shielding our patients from the reality of the situation. We maybe think we don't want to cause them distress or we don't want them to lose hope. We ourselves may be uncomfortable talking about palliative care, but hopefully through these podcasts, you might become more comfortable with that. We also might be protecting ourselves from our own emotions or from the emotional reactions of the patients and the families. However, it's really good to remember that most patients, with some exceptions, generally want to be told the truth. Most people know through intuition or reading between the lines that they have a serious and potentially life-threatening illness. Lying or withholding the truth may increase distress and distrust. Not being transparent about the truth or reality of the situation can deny individuals and their families the opportunity to make informed decisions and adapt their lives to more realistic goals and hopes. While most patients do want to be told the truth, the extent, format, and timing of the information may differ. All patients should be given the opportunity to express their desires regarding their information needs. Keeping in mind that some cultures, it is more common for a patient to defer communication and treatment decisions to a family member.
Can I just
So,
jump in here for a second,
yeah.
Brooklyn? I think that that's such an important specification because telling someone the truth can really be expressed in many different ways, and it can be a super simple truth, like this disease is a serious disease. And sometimes just saying something plain language like that really has an impact. So, thank you for bringing that up because it's super important.
Yeah, definitely. I agree. So, some questions that we want to consider when determining whether or not to have a conversation about palliative care may include what is the nature and course of illness? Some illnesses may have a clearer illness trajectory, such as incurable cancers, while some illnesses, such as chronic conditions, it may be a little bit more difficult to determine the trajectory of the illness. So, where is that patient on that illness trajectory? What options are available for treatment? Will those options cure the illness? Will the treatments increase the length of life or improve quality of life? Or will that treatment cause more burdens and outweigh that burden outweigh the benefits of that treatment? And as we've already talked about, what does the person living with the illness want?
Can I also just jump in there?
Mhm.
When you're talking about where the patient is on the illness trajectory and then what they want, of course, those are interlinked. It's always really interesting to hear what the patient thinks on where they are on their illness trajectory as well. And that might
Mhm.
kind of help you guide those conversations.
I also really like when we're talking about illness trajectory, I also really like sharing visuals with patients. So, the steady, steady line of maybe organ failure, organ disease, and then the big dips. And they get more frequent, and then they get closer and closer together, and then they get longer, like people get sicker.
Mhm.
So being able to show someone that illness trajectory in a visual format can also be super helpful.
That's a really good tip, Danica.
Yeah, Danica, I really appreciate what you're saying with those really frequent dips. So usually we see those, for example, a patient with heart failure, we might see those in the form of more frequent hospitalizations.
Are there any other questions that you guys consider when discussing palliative care with your patients?
Yeah, whenever I discuss palliative care with different people, I also want to make sure that I'm being aware or asking what options are available for symptom control or palliative care in their setting or in their community and what resources are also available. So it's really important to be able to offer something that is actually realistic.
You mean you're not going to offer 24-hour home care for a patient?
I wish that were true, but unfortunately.
Hint, hint to the powers of be that are listening. Is there anything else we should be considering, Brooklyn, when we're having these serious conversations?
Yes. So when we do have these serious conversations, it's also really important to explore or consider the environment. So we want to ensure that the environment is quiet, it's private if possible, not when there's a bunch of people around or out in the hallway. Seeing if we can find a place that's a bit more quiet and private. We also want to make sure that the person has a support person available. Is there anyone they want to be included in that conversation? So maybe sometimes we have to accommodate that and come back and have those conversations a bit later when they have that support person with them. Do be aware of your own body language. If you can, sit down at eye level with the patient. It just helps with that therapeutic relationship and can definitely make a patient feel like they're being heard and more listened to, being at kind of an equal level with them. Do keep in mind that these conversations around palliative care can be very difficult and emotional. So we want to meet the emotions with empathy.
I actually have a story about that if you want to hear.
Yes, please.
In talking about having these really difficult goals of care conversations with a healthcare practitioner the other day, the response was, or really the question to me was, how do you have these difficult conversations about goals of care? Everybody always starts crying. And the question was, do you proceed? Do you stop? What do you do when people start crying? What would you guys do in that scenario?
Let them cry.
Hmm.
Mhm. Yeah,
But
and meet them there, validate their feelings, right? Like this is an emotional time, right? So, and being there to support them and validate them will speak volumes to the family and the patient.
yeah, and it is also really interesting. I mean, perhaps this is generational, but in my opinion, crying is healthy. It's an emotional outlet. It's a very natural response.
Mhm. For sure.
There's a communication technique that I really like called reflection. So it seems obvious, but it works so well, even with my toddlers. When you see someone being emotional, just naming it, like, wow, it really looks like you're sad. It really looks like you're upset. And then pausing, and people will tell you so much. And to give them the space and the opportunity to express how they're feeling, sometimes people haven't actually had the chance to do that in their illness trajectory, and they've never had time to sit down and think about it. And so that can be really powerful.
I can't wait to get more into the meat of these having these really difficult conversations in a future podcast episode.
And I guess a last little tip when we talk about palliative care with our patients is actually knowing what palliative care is versus what it is not. So, palliative care comes with its misconceptions, both by healthcare providers and the public as well. So, when you yourself have a better understanding of what palliative care is, you can better advocate for palliative care and also provide education and support to your patients and dispel some of these misconceptions. Being aware of the words you use to describe palliative care and how you present it can make all the difference. So instead of focusing on what palliative care is not, emphasize what palliative care is. So it's an extra layer of support to help deal with stressors a patient may be facing due to a serious illness. It is appropriate at any stage of the illness. It can still be provided while seeking and receiving medical treatment. It provides expert level pain and symptom management, and palliative experts will have that time and expertise to talk about what your goals are and help plan care around those goals.
Thanks, Brooklyn. That might actually lead us into the next question or category that we'd like to address when you're talking about focusing on what palliative care is not and emphasizing what palliative care is. What are some myths that we often encounter when talking about palliative care?
Ooh, this is really good and probably my favorite. Just some myth busting about what palliative care is and what it isn't. And hopefully we've already highlighted and dispelled some of these myths in our conversation. But let's go through some of them. So, number one, palliative care is end of life care. Fact. Yes, end of life care is an important aspect of palliative care, but it is only part of what palliative care is. End of life care focuses on comfort when somebody is in their last weeks of life. It includes grief and bereavement support too. These patients typically have a C1 or C2 goals of care designation, but palliative care is not just reserved for C1 goals of care designation. A palliative care approach can be implemented even for patients who are still pursuing treatment. A palliative care approach can be implemented at any point in a patient's illness journey, even the day of diagnosis. So, even someone who's an R1 or an M1 goals of care may benefit from a palliative care approach to help manage their symptoms and improve quality of life. One of the commonalities between end of life care and palliative care is that they offer a holistic approach to care to ensure quality of life and well being.
I might just add in there that it is absolutely possible for someone with a M1 more medically focused goal of care for them to be actively dying in the next hours to days.
That's a really good point.
So look on conversationsmatters.ca for more information about R versus M versus C goals of care.
Perfect. So, another myth we have about palliative care is that palliative care is just for people who are dying. So, I hope by now you have realized that it's not just for patients that are dying, that it can be useful for anyone who has a life-limiting illness to help manage their symptoms and improve quality of life through a whole person-centered care. So, it is not dependent on the time left, and many patients receive palliative care months, even years before death occurs. Another myth is that palliative care makes death occur sooner, and the fact is palliative care does not make death occur sooner. It helps improve comfort and quality of life from diagnosis until death. Some research has shown that an early adoption of palliative care can help some people live longer. When a palliative care approach is started earlier, patients often report a higher quality of life than those who wait.
That's so true. In my experience, I've had patients who had time-sensitive goals to attend, like, a wedding or a birth or a graduation, and other healthcare teams, not palliative healthcare teams, told them that that would not be possible, but when they were moved onto our palliative care unit, they actually were able to make it to their special event. So it just goes to show that a little symptom management and person-centered care can actually go a really long way.
Yes, I've been a part of some of those stories, and they are pretty incredible to be a part of. Another myth that we have is that palliative care is just for cancer patients. So, any patient with a life limiting or incurable illness can benefit from palliative care. So, some examples may include COPD, CHF, dementia, ALS, or Parkinson's disease.
Brooklyn, what would you say then if people say palliative care is just for old people?
Oh, this is my favorite. Because often when people ask me what I do and where I work, and I say palliative care, and they go, "Oh, so you just work with old people?" And I like to go into a big rant about that. No, palliative care is actually for any age and for any patient that has been diagnosed with a life-limiting illness. So, unfortunately, palliative care can also be for some of those pediatric patients as well.
I will also just add into that for a long time, I don't know what the most recent stats are, but the unit that we were all trained on, tertiary palliative care at the Grey Nuns, for a long time, the median age of the patients there was around 45 to 50.
Mhm. Yeah, that was definitely probably the most shocking thing when I started on the unit too, was to realize like the ages that we're actually caring for. We're not the elderly, so to speak, but a lot of the middle-aged groups as well. So another myth is that palliative care is only provided in hospitals. The fact is, palliative care can be provided in a lot of settings. This does include hospitals, whether it's a palliative care unit or through consulting services in acute care hospitals. Palliative care can be provided in hospices, long-term care facilities, and it can also be provided in the community. So that means patients can receive palliative care in the comfort of their own home. Another myth is that palliative care means the patient's doctor has given up and there is no hope. So, palliative care helps people achieve their best quality of life for the rest of their life. Through the illness journey, the focus may change from curing the illness to ensuring best quality of life by addressing physical symptoms and needs, but also addressing spiritual, psychological, and social concerns. Palliative care can be beneficial through the illness journey. So maybe in the early stages, palliative interventions might just be as simple as some pain control and maybe a small part of the overall care. But as the illness progresses, some reversible problems may become irreversible and the focus shifts increasingly to comfort and maintaining quality of life.
Yeah, I really like this fact that palliative care is not about losing hope. It's actually about reframing hope. So, in palliative care, we have the opportunity to explore with patients what is important to them. And it comes back again to that patient centered care, which we've mentioned multiple times, but helping people figure out what brings them joy and what brings them hope in a new way, given the context of their serious illness.
That's a special kind of privilege, hey?
Mm-hmm.
It's pretty special.
I like what you added there for this myth, Brooklyn, in terms of palliative care, meaning the doctor has given up. There's no hope, because a lot of what I hear is that comfort care means complete withdrawal of care, and it is surprising how many practitioners will actually believe this. But comfort care doesn't mean we're withdrawing care. It means we're refocusing care based on what is actively going to make the patient more comfortable.
Very good points. And our last myth is that palliative care is only for specialists. So, a palliative care approach can be provided by any member of the healthcare team in any setting and is not just reserved for people who work on palliative care units or in hospices or work on consult teams. Jen has already helpfully given some useful tips on how to provide palliative care, even if you're not a specialist.
Yeah, so hopefully with this information, you, as any healthcare practitioner, would be able to flag patients who might benefit from a palliative approach for the most responsible practitioner to make a referral to a palliative care specialist, usually for symptom control or for hospice placement within the Edmonton zone. Well, thanks, guys, for participating in this episode of our Introduction to Palliative Care on our new podcast, the inaugural episode of Care Chats. Let's get comfortable with palliative care.
Yes, and hopefully, with all this information, advocate for palliative care for your patients and have a better understanding of what it is.
It was really fun chatting with you guys, and I hope we've empowered all of you listeners to understand palliative care a little bit better and, like Brooklyn said, advocate for the people who need it.
Stay tuned for our next episode. See you next time.
Bye.
Bye.